going to talk about tuberculosis. TB. What is tuberculosis? Tuberculosis is a disease caused by Mycobacterium tuberculosis, a bacteria. How is it spread? It is spread through air droplets. It's airborne. When someone has TB disease and they are coughing up droplets containing TB in the air, in the midst of congestion or poor ventilation, other people may inhale the droplets and they end up developing TB. When somebody is infected, they can either in a short period of time develop acute TB disease, or indeed live with a TB infection for many years, and they only develop the disease when there is lowered immunity. When the immunity goes down, then the TB becomes active and causes disease, as though it is an opportunistic infection. Most of us in Zambia are infected with TB, but we do not have the disease. But when our immunity goes down, we may develop the TB disease. How is TB diagnosed? First, I'll talk about what may make you suspect that a patient has TB. The patient may complain of a cough, usually a long-standing cough for more than 2 weeks, associated with what we call constitutional symptoms. What are constitutional symptoms? These are non-specific symptoms, not specific to TB, such as weight loss, loss of appetite, associated with drenching night sweats, sweating to the point that the beddings get wet, unexplained weight loss, unexplained loss of appetite. These are non-specific. Even when a patient presents like that, that is not diagnostic of TB. TB is confirmed by microbiological examination, bacteriological examination. What do I mean? Meaning you collect samples and take to the lab so that the people in the lab can identify or indeed isolate the organism Mycobacterium tuberculosis. And usually we send a sample of sputum. The reason is that TB enters through the respiratory system most of the times. So you are likely to find it in the sputum. Even when somebody is coughing, you induce the sputum, you are likely to find the TB. The test of choice currently is using the machine Gene Expert MTB. The advantage of the Gene Expert over the smear microscopy using Zero-Nelson stain is that Expert MTB has an additional advantage of detecting resistance of the TB to one of the TB drugs called rifampicin. So when they are reporting from the lab, they will write MTB detected, that is Mycobacterium TB, tuberculosis detected, then rifampicin resistance detected, or rifampicin resistance not detected. They will abbreviate RR. RR not detected, meaning rifampicin resistance not detected. Meaning that the the TB drugs, I mean the tuberculosis, can be cured if a patient takes the rifampicin containing TB drugs. Okay? And the beauty or the importance of that is that we're able to detect drug-resistant TB early, as opposed to the old guidelines where we were first doing diagnosing TB using microscopy, using zero staining, which was not able to look for resistance. The most important TB drugs, first-line TB drugs, is rifampicin and isoniazid. If a patient has resistance to rifampicin and isoniazid, we call it multi-drug resistant TB, and it's a very difficult disease to manage, because the drugs that are used for drug-resistant TB are less efficacious but more toxic to the body. So by all means, we need to ensure that first, patients do not contract TB. Then two, when they contract TB, we ensure that we advise them on how to keep themselves well so that they don't develop immunosuppression. And when they have symptoms, we quickly diagnose them before they spread to other people. BCG helps. It's a vaccine that helps to prevent severe forms of TB. BCG is given at birth from 0 to about 14 days. It's best given at birth, but it can go up to 14 days. BCG does not prevent you or a person from contracting TB. It merely prevents severe forms of TB, so that when you have TB, it's not severe enough to kill you or to have you hospitalized. That is the purpose of the vaccine. And in any case, most of us are scared of dying. So after diagnosing or TB, or indeed before we talk about diagnosis, the other modes of transmission for TB is through milk, and milk which is not pasteurized. But we are lucky these days, most of the milk is pasteurized. But if someone drinks unpasteurized milk, they can end up with bovine TB. And most of the times, it causes disease in the gastrointestinal system. The patient may present with ascites or distension of the abdomen or abdominal pain with constitutional symptoms. And when you do an ultrasound, most of them you either find ascites or indeed enlarged para-aortic lymph nodes along the aorta, abdominal aorta. If TB is not controlled, it can spread to other parts. So you may end up with extrapulmonary TB, TB in sites other than the lungs. For example, it can spread through the lymphatics to the lymph nodes. So a patient may present with painful lymph nodes, okay? What we call TB lymphadenitis. It can also spread to the brain through the bloodstream, and the patient may end up with TB meningitis. It can spread to the spine, and the patient can end up with paralysis of the lower limbs, paraplegia, a common presentation. Rarely, TB can even go to the genitals, to the urogenital system. Okay? So, diagnosis of TB in the extrapulmonary sites in addition to examination of sputum, you also do tests specific for the system you think is affected. For example, if it's TB meningitis, you have to do a lumbar puncture. You may have to do a lumbar puncture. Okay. What do you find when you collect the CSF? Even before you examine it using GeneXpert, you find that when you just let it settle down, maybe for about an hour or so, you find that because it has a lot of protein in it, okay, due to chronic inflammation, the liquid, the CSF, is going to form spider webs inside because of clotting of protein. And indeed, when they do CSF biochemistry, they are going to find high protein, which signifies TB. The yield for CSF for TB is quite low, about 15%. So the absence of, or the negative GeneXpert or Ziehl-Neelsen stain for CSF does not exclude TB. So we use surrogates such as measuring the amount of protein in the CSF. Okay. For TB lymphadenitis, TB of the lymph nodes, you do biopsy of the lymph nodes, and you take a sample of the lymph nodes to the lab for histopathology. The pathologist examines, and when they make a cross section, in fact even the surgeon can do that, they cut across. Characteristically, lymph nodes which are enlarged due to TB look yellowish in color. Okay, they look like cheese, what we call caseation. So if the surgeon, even before they send for histopathology, they report that there was caseation on a cross-section, macroscopic examination, you start the TB medication. Even before you wait for the staining, you treat what is common. Of course, there are other causes of caseation, but these are rare, like sarcoidosis. Common things are common. If a patient has a TB spine, you still examine the sputum. You are likely to find something in the sputum. And sputum examination is done for all patients who are suspected to have TB, whether it's extrapulmonary TB or pulmonary TB. In terms of treatment, you have a combination of 4 drugs, what we call the 4FDC. It contains rifampicin, isoniazid, pyrazinamide, and ethambutol. They are conveniently combined in one tablet so as to reduce on the pill burden, okay, so that the patient doesn't swallow too many tablets. And these are given per kg body weight. Whether it's an adult or a child, they are given per kg body weight. You don't need to memorize the dosages because you're going to give the kg body weight, and you refer to the charts as the patient is coming for review. So every time a patient comes for review for picking up the medicine, you weigh them and give them medicine according to the weight. In any case, when they start taking drugs, they gain weight. So a patient may not be on the same number of tablets or the same dosage from beginning to end. Along the way, because the appetite will come back, they gain weight. So you find that maybe they started with 2 tablets, they end up with 3 or 4 tablets by the time they finish the treatment. Then, in terms of pathogenesis for children most of the times they still get reactivation, but most of them end up with what we call primary TB. There's primary and secondary TB. Primary is where you get infected within a short period of time, weeks to months, you develop the disease. Then reactivation, of course, comes after many years when the immunity goes down. Okay. In terms of treatment, you categorize the patient, okay, into non-severe disease and severe disease. Non-severe disease, the treatment is for 6 months. Intensive phase, 2 months. Continuation phase for 4 months. Then severe forms of TB, like TB meningitis, you treat for a total of 12 months. 2 months intensive phase and 10 months continuation phase. At 2 months, you check sputum. If it's negative, you change to the continuation phase. Okay. If it's positive, you suspect. If it's still positive at 2 months, you suspect treatment failure, or you revisit the adherence and compliance of the patient, as you send samples for resistance testing, so that you identify resistance early. Okay. So those patients that went positive from the beginning and they are negative at 2 months and at the end of treatment are labeled cured, and they are allowed to go back into the community. Then those who were negative from the beginning, maybe they had TB spine, sputum was negative, but still a diagnosis of TB was made. When they complete treatment, we simply say they've completed treatment. We don't say they are cured. Yeah. And those who die, we say they died. So those are the things we wanted to talk about today in terms of TB. Thank you.